Joined late. My name is Lisa Bailey. I'm your moderator for this session, and I am Specialist Communications for Health Promotion with the PAHO Caribbean Office. So today we're going to be starting off with Tanya. She'll be doing the basics of risk communication and community engagement. We started talking about this yesterday, and I know there's a lot of interest in this.
Good morning, everyone. Very nice to see you again today and meet the people that just introduced themselves that couldn't be here yesterday. My name is Tanya Escamilla. I'm the communications specialist at the Health Emergencies Department at PAHO in Washington, and I support risk communications and community engagement advice for member states. So I'm gonna start with a presentation on the basics of risk communication. And the presentation that we're gonna see first, it's grounded within the international health regulations. So we are, on the same panorama where the international health regulations gives us, the main functionalities of risk communications and community engagement. Okay, so let's start with the framework and the IHR, which is a legal instrument, and it's been approved or supported by 194 member states. And most importantly, member states need to report on the IHR every year. And we're going to look into what they report for RCC, which is one of the core capacities of the IHR later on. And the main purpose of the IHR is to establish, the procedure so that countries report to WHO on health events, specifically for WHO pandemics, and epidemics. So that's, WHO is like the UN agency that within the IHR receives the reports from countries specifically in that front. But more than the response, also the IHR gives us a framework in order to have preparedness, to have prevention, and also to have recovery if we do go into response. So these are the 15 actual IHR core capacities, and I say actual because they were modified on 2018. There were 13 core capacities. For right now, we have 15 core capacities. Risk communication and community engagement is the 10th core capacity, but you can see the other ones here. And what a core capacity means is that the country needs to prepare and also create the ability to report on all of these capacities. I just included a little picture to the international health relations, but you're gonna have this presentation and you have the link so you can read it if you would like to do that. Okay, so how do countries evaluate and how WHO has requested the countries to evaluate on this IHR core capacities? There's an annual assessment, which is binding, and countries need to report before the World Health Assembly every May. So before WHA in May, countries need to send in a tool that's called eSPAR, and SPAR stands for the Self-Assessment Tool for Annual Reporting. So there's an eSPAR, it's an online platform where countries say and evaluate on these 15 core capacities and each of the indicators of the core capacities. So for risk communications, and I also wanted to highlight here that this is you would also have the link in the presentation for the SPAR, and this SPAR explains very well, how countries report, what indicators need to be taken into account for each one of the 15 core capacities. Of course, we're gonna center today on risk comms and community engagement, but I just wanted to point out that there is this document that explains better, the framework of the IHR annual evaluation. So the three indicators that we have for risk communications and community engagement are risk communication system for emergencies, one that's called risk communication and community participation or community engagement. And we're going to look into detail, what does that mean? What each one of these indicators mean. So as I said before, the countries submit their annual assessment on capacities before May every year. So the first indicator, and risk comes within the IHR, it's, I guess, cataloged or processed with the numeral C10. So each one of the indicators will be C10.1, C10.2, and C10.3. What do the countries need to report? They need to report in which level they are. So these are the levels for the first one that's called RCCE System for Emergencies. What's your capacity to have risk communications and community engagement in order to prevent, to prepare, to respond, and to recover to pandemics, epidemics, okay? So here you can see the levels that we have. Of course, if you see level 1, it's only having mechanisms for coordination for a number of functions, but when you read on the different levels, that expands. And that's what the country says, I have this, I'm at this level. And the system where they report into it turns this level into a percentage. So how much have you achieved during the year? What percentage you're on? And we're gonna see later on how the whole sub-region has been reporting. So you have a knowledge on what your countries are reporting to the IHR, the ones that do report, because there's a couple that don't report. For C10.2, which is risk communications, it pertains more to external communications. So we have here indicators around media, around public affairs, around public relations, but one of the main introductions 4 years ago was the infodemic management in some of these levels. So that's digital communications, social media listening, and how do you respond to those aspects. And of course, level 5, you have everything, right? You have media relations, you have including infodemics, you have a cross-sector strategy at national and subnational levels. So here you can see, the different levels that this indicator has. The C10.3 takes us to community engagement, and this indicator really talks about health promotion and some of the work that you have so many years, have so much experience and been doing for so many years. Because community engagement cannot be achieved without the basics and the base that we have from health promotion and the really important work that health promotion historically has in all of our region. So how do you engage with the public? You have a mechanism, you have a coordination between risk communication teams and health promotion workers. You use health promotion information from communities to inform your risk communication strategies. And again, the different levels, just level 5, there's perfect coordination for health emergencies. You have guidelines, SOPs, qualitative and quantitative social behavioral data that's being analyzed constantly. So that would be like the ideal. And here we can see, and I hope you can see it better than I am seeing it. I don't know why it's a little bit shady, but here we can see how the countries have been reporting, and this is the data that we have for 2021. So this is the data they submitted this year before the WHA, and you can see, well, we have 3 countries that did not report. And this report is done by the national IHR focal points that usually are connected with the Ministry of Health in order to properly report on the percentages. So, for instance, Jamaica says that they have 100% in everything. So everything's very good in Jamaica, for instance. And we also have St. Kitts and Nevis. So what we're trying to do is, and this is, I really appreciate having this space. So we have a better comprehension on what the indicators of the IHR mean, so we can, advise also on how, how to evaluate the country capacity. I just wanted to ask if you have any questions up until now, because I know this is a lot to take in, but if anyone wants to make a question. So here are the 3 indicators. So this is C10.1. So this is risk communication for health emergencies. So that's the response. This is 10.2, which is public, external communications and infodemic management. And this is 10.3, which is community engagement. You here have like the overall evaluation from the AMRO region, but that's all of the Americas. And the ones that you see in red is because they are lower than 40%. So the ones you see in yellow are between 40 and 60%, and the ones that you see in green, the country reported they're between 60 and 100%. So the green ones would be the ones that are 100%. They have level 5 on every one of the indicators. So that the maximum level, the green level. But you can see here that the punctuation varies, and that's depending on which of these. Let me show you. You see there's level 4 and level 5. So if you say level 4, the system calculates that into a percentage. So that can be 80%, for instance. If you say level 5, that would be 100%, right? One of the main aspects that the IHR is trying to, well, not tries, but it definitely highlights as very important is the stance and the concept of, multi-hazard emergencies, and how we need to prepare in each one of these indicators for different types of emergencies, and have the event grading and the response. And this pertains to the procedure that needs to be done once the outbreak or the epidemic is detected, or there's scientific data that tells us that there's an infectious outbreak. So the multi-hazard approach also emphasizes to countries that even though WHO is the standing agency for infectious outbreaks, there's also another threats that we recognize for each of the regions, and specifically for AMRO, of course, we have hurricane season, we have vector-borne diseases. So that will fall into this multi-hazard standpoint for the IHR. And the multi-hazard concept, I think it's very important to understand how risk is defined, but also how people perceive risk, because that's where we're going to move forward, to how people perceive risk and receive our communications when they feel at risk. So it really depends on the type of hazard and the probability on the hazard occurring. So for instance, hurricane season in the Caribbean, people have, already a knowledge and they are, very aware of that the hurricane season may come, that there's preparedness activities that they need to carry out. But maybe for other types of hazards, there's not that type of integral, comprehension. And that happened to all of us when we had COVID, because we thought that would never happen, a pandemic that will keep you at home for months and months and months. So how people perceive risk is really influenced on the type of hazard and the probability that people perceive of having that risk occur. And how do we assess risk, and where does risk communication come in and community engagement? We assess risks, with our scientific information. We manage those risks with, the policy and decision-making and legislation that we have at hand. But we need to have risk communications and community engagement in order to have a two-way communication, so that people are informed on those risks and know what they can do to manage their risks, right? So we need to build trust, have community involvement, and empowerment, and that's where risk communications comes in within the risk assessment and the risk management cycle. And to the basic concept of, what WHO and PAHO promote risk communication and community engagement. Of course, the exchange of information, but what I want to highlight here is that we emphasize that it's a two-way street. There's no longer a passive audience. There's no longer, this time where we saw, I was just talking to some colleagues in the breakfast, where people saw the TV and they didn't question anything that they saw in the news, or they didn't react to something, a content that they received. If they, walk past a billboard, they wouldn't question everything. That time is gone, and now we all react on what we think over social media, and that's, the main important thing is that risk communication and community engagement needs to be, a multi-directional type of communication, but also understanding that your audience or the people that you are trying to get to have their own opinions or cultural values. Of course, now we are very much appreciative of that, but they also understand risk and perceive risk in different levels, depending on their social, cultural, and economical context, right? And these are the guiding principles of risk communications. We talked a little bit about this yesterday, but of course, once, in the framework of the IHR, which is this scenario we had in COVID where the outbreak was coming, be first, be fast, be frequent in communicating to the public, but also with, transparency and saying exactly what you know, but also saying what you don't know at the moment. Communicate even in the face of uncertainty, speak with one voice, and many times this is hard because, we talked about this yesterday. The president may say something, the Ministry of Health say something different. We have different standpoints, maybe at different levels of government. But ideally, we should speak with one voice, and that includes also partners and other stakeholders. Listen and respond to concerns and showing empathy, and this takes us back to, being non-judgmental, even in the most complex circumstances. I think these two are very key to understand where people are coming from and where the hesitancy, if we speak about vaccines, is coming from, Involve and engage communities, and of course, we do this, and our teams do this through health promotion and have done it for many, many, many years. Of course, some of you here have all the experience in that field, but we really need to emphasize that knowledge from the field needs to come in this concept of, risk communications and community engagement. And of course, the integrated approach that will lead us on to build a national capacity and ownership of a risk communication strategy. This all to, get to the final highest outcome, which is creating and maintaining trust. And we also spoke about this yesterday, how, healthcare workers were taken out of the picture in many countries when COVID came, and, politicians took over, or some other profiles in the government, and that affected, the trust that the people had in their response and the actions that were being taken to respond to the pandemic. What's going on? Okay. So talking about trust, right? And talking about this new audience that will not listen to you and not question you about anything, Which doctor would you trust? Someone that's hopeful and positive, that shares only and talks about what she knows and is honest about what she doesn't know, that describe what, the next steps, takes you step by step and takes the time to explain to you what's going to happen, and shows expertise in her field, or someone that's, straightforward, telling you what you need to do, what you have to do, discusses all the negative stuff that could go wrong, first and foremost, shares what she's not sure of and that she cannot guarantee, on what she cannot guarantee, and makes emphasis on that, and gives advice on what you need to do next, almost in this kind of, giving you a an order of what to do. So these are the two types of, this is an example of, how do we engage with communities and how that trust even starts when the patient or the person seeks medical advice, and why do we need to go back and work with our healthcare workers in order to inspire them to have a more trustworthy attitude towards patients. And I think it's very interesting what we saw in Lisa's presentation yesterday in the results of the survey, because, how can we proactively engage healthcare workers and in our countries in order to be more open to have, a different approach towards, towards care, a non-judgmental approach towards care, but in the midst of, having systems and services of health that are, to the max capacity. So it's a very intricate and complicated, challenge that we have, but we also need to be clear on, as a patient or as a person that's seeking care, what are the views from that standpoint, and understand that standpoint. So understanding risk perception from the patient or the audience standpoint, of course, is a subjective judgment. It's also based on beliefs, rational or irrational. And as we saw before, we combine the hazard, but also with the emotional response. And we're going to talk a lot about emotions and how, information needs to be compelling in order to create that emotional response and lead people to action. Okay, so how do people and the public think about risks? Here we have like a little illustration. So here's the real risk. This is the expert risk perception. This is the public risk perception, but here in the expert standpoint, of course, decide what is risky based on the analysis of the hazard, of the menace that they have. And for the public, decides what is risky based on their values, emotions, and concerns. So the perception is going to go in different directions given the way that they are grounded on. And the challenge that we have is to center people and the audience the closer as we can to the real risks with facts. And with compelling activities and materials and initiatives. So risk perception in people's minds are a main driver for risk communication and community engagement. And of course, we spoke again about this yesterday, perception rather than fact drives public action in an emergency. And that's why we need to work on those perceptions before, and be prepared before, and be working proactively into public messaging and social listening activities before the emergency comes, so we can act on people's perception of a risk. And here just sharing why risk communications is important. Of course, listening and responding to concerns, sharing information quickly in ways people trust, building trust and understanding, engaging everyone in fighting disease, and of course, something that's really important and that we saw and lived and experienced in COVID, stable economies and communities, So we're gonna start talking about, and I wanna frame infodemic management within, social and behavioral insights, because that's actually the ultimate objective of doing infodemic management, to have greater knowledge of what people's behaviors are in order to act on and respond to those behaviors in an appropriate and culturally sensitive manner. So just the basics of social and behavioral data for people that many of you here that have worked in health promotion. Again, this takes us back to UCAP studies, knowledge, attitudes, and practices or behaviors, to understand drivers and barriers that influence behavior, and to inform also policies and programs, but of course a response to a health threat. So why collect social and behavioral data? And this is something that again, health promotion teams already do and have done for many, many years. Maybe not in the formats or asking the same questions that we have today, but this is something that has been done, a while ago. To inform behavioral interventions and, have a strategy for people to adopt health behavior or change a behavior on healthy practice. To ensure we focus on the right topics by understanding information gaps and needs. Correct false beliefs and misinformation, of course, that takes us, it taps into infodemic management. And to inform, assess risk communications and broader emergency response, and this pertains also to preparedness. If we don't have the data beforehand, how are we we're not gonna be able to respond once the emergency happens. And finally, of course, creating that two-way communication so we can also have accountability towards the community and the audience. And accountability, ultimately will build on that trust that we need. If we are not accountable, people are not going to trust us. So these are methods and for data insights collection. And of course, recently, in the recent years, a lot of digital tools have been put into data insights. So before, we used to have a lot of face-to-face surveying, going house to house. But one of the key challenges with COVID was what we weren't able to go into communities and collect the data. So COVID produced like a rise of digital tools to engage with communities, engage with people. But I think that really important is to keep in mind that either way you're collecting the data needs to be framed within a strategy of what you're going to do with the data that you're collecting and what objectives and indicators you're pursuing with that data collection. So it doesn't matter if you use focus groups or online surveys, polls, or WhatsApp groups. You need to have a clear strategy and methodology beforehand on what you're trying to achieve or what do you want to know about that community with the data that you're collecting. So, of course, the challenges that we have, we needed so badly social listening and infodemic management. We need it to be really fast, and we need it right now, and we need it to be of quality. However, we have to have a starting point, and we're not going to start with everything in place. Having the human resources, the platforms that we need, the teams. So we stress this idea and this concept that it's better to have an imperfect social listening and data collection system that is regular than to wait to have something done perfectly once the emergency comes. And I think that we need to talk more, from the communication departments, and I say from because I am a communications person as well. We need to connect more with, colleagues that are out in the field collecting data from the communities and trying to put that into our own, systems or surveys that we are doing. There's a lot of, surveillance work that includes surveys in communities. For instance, epidemiological surveillance. So how do we connect that information with our work in social behavioral insights and social listening and infodemic management? That's really key. These are examples of methods to collect information and outcomes that we may pursue in a strategy. So of course, knowing what people are talking about online and offline, having that feedback and having that involvement with the community once we are designing the strategy and the actions that we're gonna implement. Have public insights of what's going on, trending topics in the media, and I think there's no media outlet, call it newspaper, magazine, that doesn't have already a social media account, a website. So they're all the ones that are remaining to be offline already online also. So we need to, of course, collect data from them, capture information with selected individuals that are representative in a community, and key informant interviews, what we call the structured interviews with leaders, prominent community people, community influencers as well. And the topics that we are going to monitor and what we can collect with these methods, of course, our, perceptions, and in some instances, also we can map out, and that's where we're going to connect with pre-bunking. What are the rumors, myths, and misinformation that are circulating in order to, act on them beforehand, before they become, an infodemic. The needs and concerns of the community, and that also connects with, their access and their ability to have healthcare services. Solutions, what do they think that, we should do? What do they think that we should do together with them? And how can we raise their role and empower their voices and their groups and their leadership? Also map out who's influential to them and who might work, besides a healthcare worker, the Ministry of Health, who can we communicate with them, get our message through that person or that group in order to connect with the community. And of course, evaluation, and what are we producing? So what are we producing? Is it really useful for communities? Sometimes we don't want to hear it. Maybe it doesn't work. Maybe communities say, it's not working for us. I don't understand, what we're trying to say. It's so confusing, the changes in the vaccine and how many boosters I need to take. I don't understand anything anymore. We need to hear that and see how can we act up on that. So of course, what I spoke about before, COVID gave a lot of prominence to the online methods, but it also comes with disadvantages. I mean, face-to-face and interpersonal communication, in my opinion, but of course I'm 40 years old now, will not be replaced by digital. Maybe in 20 years, when someone sees this recording, is gonna say, that person was crazy, because it's all gonna be virtual reality and, the things that we have now. But there are disadvantages right now in this day and age to collecting or using only online methods. Of course, not everyone has access to a smartphone, knows how to use one, or has reception when they have a smartphone. And digital literacy is a big issue. Of course, we are not establishing a personal collection, and people do behave different online. There's a lot of studies that tackle into this, how people, when they think that no one is seeing them or no one can identify them, they act different than in their real lives. So the conclusions that we get from online statements may not be, a clue on people's actual behaviors. Of course, there's many advantages. So how do we combine in order to, balance out the advantages and disadvantages? I really think that we need to keep pushing for online and offline. And that's why I really emphasize that connecting in multidisciplinary teams where we speak with people that are in the field for different purposes in public health is so key. We cannot keep working in silos. I work in the communications department. I'm not going to speak with surveillance. I work in the communications department. I'm not going to speak with, the EPI manager. So, or the health promotion specialist. How can we form and advocate for more multidisciplinary teams so that we balance out, this disadvantages and disadvantages on social behavioral insights? And ruling out means that, of course, the offline method has advantages and disadvantages as well, that we can, it costs more, takes more time, PHSM restrictions. If we have another pandemic of, respiratory viruses, we may not be able to go into the community. That happened to us during COVID. The bias during face-to-face interaction because people don't know who they're giving the answer to, or trying to be nice all the time and saying, oh yeah, no, I believe in everything that the Ministry of Health says. I'm completely, aware, and I'm gonna get the vaccine tomorrow, because people are trying to be courteous when you ask them. And because it is very costly and you need many teams, it's not possible to reach a high number of people in real time, and that can be ruled out by combining the digital and the offline methods. But of course, there are many advantages still, and Of course, in many communities, face-to-face will make a huge difference, especially in our countries, in our settings, and in our culture. Latin America and the Caribbean is very much about connecting and feeling the presence of the other person. So we have this culture, very social cultural. And of course, the establishment of personal relationships. If we want to go into a community and empower them, you need to really get to know the leaders, the way they think, the way they behave, why do they behave like that, and how you can support them better in order to reach and engage the community. So how to ensure that the findings are, informing the broader response? We, as I said before, we need to have a strategy beforehand before we start collecting the data. So it's not to check something that, oh yes, we are doing, social behavioral insight time. How are you going to use that data that you collect offline or online? And what's the strategy and the indicators that you're going to have and the objectives that you want to reach with that type of data? And I think that this data that you gather needs to also inform operational areas. So what we were talking about before, coordination, the sign-off process, how the community behavior can affect the coordination mechanisms when the emergency comes, and who approves what, when the emergency comes. Because maybe you'll find out that it doesn't necessarily need to go as high up as the Minister of Health approving some type of risk communication initiative. Maybe that coordination mechanism, if you test it beforehand, you'll find out that the health promotion specialist can have a go at approving some of the materials, and that way will be faster than if we wait for the highest level of clearance. But if we don't test out those mechanisms and inform and persuade that we have data that suggests that it might work better in another way, we're not going to be able to achieve that. And of course, with the social listening, what you will find is all the rumors and the conspiracy theories and the disinformation that is circulating. When you do those behavioral insights offline or online, you're gonna have a clearer picture on what type of information is circulating. And of course, here's the concept of infodemic, that's the overabundance of information, and that was within the public sphere. It already existed, the concept, but it gained a lot of notice within the public sphere when Dr. Tedros said, in March 2011, we're facing not only a pandemic, but also in 2020. We're also facing an infodemic. And the types of, data that circulate within the infodemic. So we have information, facts that pertain to facts, misinformation that maybe is not deliberately false, so people are not trying to lie, but there's misleading pieces, or the person didn't comprehend 100% and is trying to fill those pieces with information that's not really accurate. So this information that's deliberately created falsehoods, and that is like, when you go to a fake website, when you approach content that is being, spread on to someone that seems to be a doctor, but in reality is not a doctor. And this information is getting very sophisticated every day. There's so many ways and so many effective ways to produce this information, and the resources and the money that some groups put into it is really astounding. So this is really key, and this also happens not only in the public health sphere and public health with public health information. We all have a relative, my mom, my dad, who click on false emails. That's because you won the lottery in India and you need to send your debit card details. That's deliberately creating falsehoods. And then there's the rumors, that's unverified information, stories that spread rapidly. So I remember in Colombia when COVID started, there was this huge rumor that you would be cured if you bathe in the sea. And COVID wouldn't be able to reach you if you constantly bathe, in seawater. And there was no trace of that in social media, but it was circulating like person to person. Did you know my aunt went to the beach and she went in the sea, now she's COVID free. So yeah, that's type of rumors and unverified information that can circulate. So verification, and Florencia, who's coming up after me, is going to talk more about that. But in terms of assessing the information, the 5 pillars, provenance, where is it coming from? In terms of the place or that is coming from. And the place doesn't mean always the geographic place, but where in the social media sphere is it coming from? The source, what's the source of the information, the date, the location, and the motivation. And this 5th one for me is one of the most difficult things to figure out. What's the motivation to produce these very intricate strategies for misinformation? Because if we could understand the motivation, we could respond better to it. For me, this is still unclear in terms of, some anti-vaxxer groups. I don't really understand the motivation, and maybe I need to engage in a conversation and try to actually grasp what their motivation is. And maybe this happens also to you in other topics apart from COVID-19 vaccines. So debunking, pre-bunking. So when you debunk, it's already something that's out there, but when you debunk, that creates a gap. We need to fill that gap with, a factual alternative. And in order to fill it with a factual alternative, I really think that we need to be telling more stories than data. People connect with emotions, people connect with stories. So in my perception and what we have seen from WHO and from PAHO is that if people see themselves, identify themselves, or there's a feeling or emotion that pulls them to act, and we were able to fill that gap of misinformation with that compelling, compelling content, people are very much moved to go into action. That's what we have seen. And pre-bunking is acting on something, and we're going to see a little table that it's a rumor and you want to act on before it turns into a huge disinformation. So here we have the assessing of the potential impact of the rumor, and when we start considering pre-bunking, when we have low risk, it's still a limited potential, but we need to act on it, and we need to consider to act on it, not directly talking about the fact or facing off the person that's spreading the disinformation, but producing content that might be educational, or doing activities, implementing activities that can be educational towards the public before it turns into a huge thing. And the medium risks, so this is where we act and debunk and raise trusted voices, because we identify it has a potential to trigger hesitancy to vaccinate, if we put the emphasis on our meeting today. And then the high risks, it can actually lead to vaccine refusals. It's a wide scope that it has, and here we need to debunk, but we need to debunk in a more frequent way. And how to tackle rumors, deciding when to engage. Here we have a matrix of that, goes back to the table that I showed you before, but in a flow chart. And here you can see, if you have the social listening in place and you are able to identify and classify the information, you have here certain options in order to trigger or target that content. reputational risks, of course, it's always a big thing with our organizations and, of course, ministries of health. Public health risks, so information that will prevent on people to doing an action that can save their lives. And these two, for me, are very hard because, when you have a hoax or a myth or these conspiracy theories, people are so compelled emotionally about it that it's so hard to respond onto that. And of course, we need to map out and see where that's coming from. And this also includes something that we spoke about yesterday about, indigenous community diversity and their cosmovision. I don't know if that word exists in English, but in Spanish it's like cosmovisión indígena. How can we work together with indigenous communities or people that have a totally different culture than the mainstream in a way that's comprehensive, but that tackles any myths and hoaxes that they might have because of their, cultural reality? That's key.
Hola a todos, muy buenos días, un gusto estar presente en esta sesión. Bueno, muchas gracias por la invitación a participar de esta sesión. Soy Florencia Ballarino, soy periodista científica y soy editora de Chequeado en Buenos Aires, Argentina. Es una unidad de fact-checking y pertenecemos además a Latam Chequea Coronavirus, Latam Chequea Vacunas, que ha sido un proyecto que ha juntado a todas las unidades de fact-checking de América Latina para combatir la desinformación sobre coronavirus y más específicamente sobre vacunas contra el coronavirus, que desde Chequeado estuvimos durante 2020 y 2021 colaborando y un poco también liderando este proyecto conjunto. Bueno, como ustedes saben, las dudas sobre la vacunación son una amenaza a la salud global. Sabemos realmente que las vacunas previenen de 2 a 3 millones de muertes cada año y si se aumentara la cobertura de las vacunas a nivel global también podrían evitarse 1,5 millones de muertes más. Ya en 2019, previo a la pandemia de coronavirus, la Organización Mundial de la Salud dijo que las dudas sobre la vacunación, la renuencia a las vacunas, a vacunarse, a pesar de la disponibilidad de las vacunas, eran una amenaza a la salud global porque podían poner en peligro, en riesgo, todo lo alcanzado en cuanto a coberturas de las vacunas y prevención de enfermedades inmunoprevenibles. Sabemos entonces que las dudas sobre vacunación realmente es un factor que puede desalentar la vacunación. Y esto trae aparejado la reemergencia de algunas enfermedades que creíamos olvidadas. En estos momentos, por ejemplo, brotes muy importantes de sarampión en Brasil y en Venezuela. En 2020 vimos como Perú, luego de 20 años, registró su primer caso de difteria, y también hace muy poco la Organización Panamericana de la Salud advirtió sobre el riesgo de reintroducción de la polio, y esto tiene que ver con las bajas coberturas de vacunación, coberturas que ya venían a la baja previo a la pandemia de coronavirus, y lamentablemente con la pandemia y con las restricciones impuestas a la movilización de las personas, se vio realmente también afectados en toda la región. Tenemos distintas, podríamos decir que hay una amplia gama, ¿no?, de actitudes con respecto a la vacunación. En los dos extremos tenemos las personas que activamente demandan una vacuna y las que son renuentes o rechazan la vacunación. En las actitudes en cuanto a el aceptar o no las vacunas, realmente entran en juego muchísimos factores que tienen que ver con lo social, con lo psicológico, con experiencias previas a la vacunación, también con signos cognitivos, con también, digamos, valores morales. Hay muchas cosas que entran en juego, muchos factores y realmente es difícil y puede variar tanto en el tiempo como en el lugar. También tenemos personas que quizás no demandan activamente la vacunación, pero la aceptan en forma, digamos, pasiva, y un grupo bastante mayoritario, que son estas que tienen dudas con la vacunación, que aceptan algunas, son contrarios a otras, ¿no? Porque tienen dudas con respecto a ciertas vacunas en particular. Este grupo, que puede ser también mayoritario, a diferencia de los grupos antivacunas, que lamentablemente también tenemos presentes en América Latina, pero en forma minoritaria, este grupo que tiene dudas con la vacunación, si nosotros llegamos con información confiable, con información basada en evidencia científica, podemos lograr un cambio de opinión. Y a ese grupo, lamentablemente, quienes también afectan mucho las desinformaciones. Recién también Tania hablaba sobre el concepto de desinformación, ¿no? Este contenido falso, contenido erróneo, contenido engañoso, que circula a través de las redes sociales y también servicios de mensajería instantánea. Por ejemplo, en la Argentina tiene mucha penetración WhatsApp, después ustedes me contarán qué pasa en sus países. Puede ser en forma de un posteo, puede ser en forma de un video, puede ser en forma también de una fotografía sacada de contexto. Esta información errónea lamentablemente se disemina muchas veces también porque hay amplificadores, estos son figuras públicas, ¿sí?, que también difunden desinformaciones, como puede ser un político, como pasó en la pandemia un político, o figuras del espectáculo, ya sean cantantes, un fenómeno muy fuerte con Miguel Bosé, seguramente ustedes conocen Miguel Bosé en España como un gran difusor de desinformaciones sobre vacunas, y también hasta deportistas, ¿no? Actores, figuras públicas que tienen mucha relevancia y que hacen que se puedan amplificar lamentablemente estas desinformaciones. Hay diferentes motivos por los cuales las desinformaciones se producen y también se comparten. Hay tres categorías que son las mayoritarias. En el principio tiene que ver con una motivación económica, esto de generar clics, de generar views a los videos y de que esto luego se manifieste como un ingreso económico, ¿no? Luego también por razones políticas o también por convicciones. Vemos a los grupos antivacunas que difunden información que no está basada en la evidencia científica, aunque esa información es verificada y contrastada y se sabe que es falsa, ellos, digamos, siguen en su posición, la reafirman, y vemos cómo además de estar en contra de las vacunas, también difunden otras teorías conspirativas con respecto a la ciencia. Y también muchas veces se puede compartir información desinformación, perdón, por ignorancia, por no conocer realmente si esa información es o no falsa. Y eso nos pasa mucho en las redes sociales, donde muchas veces la información es compartida por una persona anónima, donde no sabemos realmente cuál fue la fuente fidedigna, de dónde provino esa información, y por eso la replicamos muchas veces sin saber si es cierta o no. Ahora, la desinformación también la circulación de rumores no es un fenómeno nuevo, lo conocemos hace muchísimos años. Recordemos que una de las desinformaciones y mitos más frecuentes con vacunas y dañinas tiene que ver con este estudio fraudulento publicado en 1998 en la revista The Lancet, que vinculaba falsamente el autismo con la vacuna triple viral, una desinformación que tanto daño le ha hecho a la confianza pública en las vacunas. Pero con las redes sociales, como decía recién, con las nuevas tecnologías, este fenómeno se amplifica, podemos generar y compartir desinformación muy rápidamente. Y esto ha llevado ya en el principio de la pandemia a hablar desde la Organización Mundial de la Salud que nos enfrentábamos a un fenómeno conocido como la infodemia, esta sobreabundancia de la información que no permite a las personas identificar la fuente fidedigna y muchas veces tomar decisiones en salud basadas en la evidencia científica. También tenemos que tener en cuenta que la desinformación muchas veces aprovecha los vacíos informativos que existen, ¿no? Sabemos que en la pandemia fue un momento especial de mucha incertidumbre, de muchas preguntas. Bueno, la desinformación se va a aprovechar de esa incertidumbre para dar difusión a rumores o información erróneas con la motivación que antes contábamos. Por eso es muy importante prestar atención a estos vacíos informativos, a estas preocupaciones que manifiestan las personas, para tratar de llegar con información que esté chequeada y que esté basada en evidencia científica y que sea de fuentes fidedignas, ¿no? Y también muchas veces ser, digamos, verídicos en el sentido de cuando hay incertidumbre, cuando hay algunas preguntas que no se pueden responder, ser sinceros, ¿no?, con la audiencia y decir, esto es lo que sabemos hasta ahora, estamos averiguando, estamos haciendo nuevas investigaciones para conocer más. Ser también entonces sinceros cuando no podemos llenar ese vacío informativo, pero siempre estar atento a todo lo que circula. Les voy a contar un poquito cómo hacemos nosotros hacemos diariamente un monitoreo de redes sociales. Ese monitoreo de redes sociales tratamos de poder encontrar desinformaciones que circulan en redes sociales, luego también ver de qué forma esas desinformaciones podemos chequearlas. Esto tiene que ver, siempre decidimos qué información, qué desinformación chequear de acuerdo a su viralidad en las redes sociales y también de acuerdo a su posible daño. Una vez que decidimos qué desinformación vamos a verificar, tratamos, por supuesto, de contactarnos con fuentes fidedignas, fuentes que sean oficiales y que nos puedan decir si esa información es falsa, si esa información está fuera de contexto, si esa información es engañosa, y también fuentes alternativas, fuentes independientes. Una vez que hicimos esa desinformación, nuestro método indica que podemos publicarla, casi siempre vamos a difundirla en la red social donde esa desinformación circuló, y también vamos a tener en cuenta que tenemos que ser muy claros cuando hacemos una desinformación desde el principio, poner si fue verdadera, falsa o engañosa, y tratar de ser también una forma atractiva en ese sentido. Difundir, por ejemplo, si hubo un video que se viralizó a través de Instagram, bueno, tratar de difundir también la desmentida a ese video en Instagram, que es la red social donde estuvo circulando. Durante la pandemia, como les contaba, tuvimos un proyecto que fue la TAM Chequea Vacunas. Vimos que muchas de las desinformaciones que circulaban en un país de América Latina luego se replicaban en otro, y así circulaban diferentes desinformaciones, pero que en realidad eran la misma, y de esta forma pudimos ver cuáles eran las noticias falsas más comunes acerca de las vacunas COVID-19 y hacer una tipología. En principio, hubo muchos contenidos desinformantes y engañosos sobre eventos adversos y también muertes atribuidas a las vacunas. En ese sentido, por ejemplo, lo que vemos es que en muchos casos se hablaba sabemos, ¿no es cierto?, que todos los medicamentos pueden tener efectos adversos, pero en el caso de las vacunas, los efectos adversos en su mayoría son no graves, duran muy poquito tiempo, pero cuando aparecía un efecto grave se magnificaba en los medios, en la cobertura que se hacía, y muchas veces también se confundía causalidad con correlación, ¿no es cierto? Si había una persona que se había vacunado y lamentablemente por factores externos fallecía, bueno, se vinculaba su fallecimiento en muchas de las noticias que se publicaban con la vacuna, cuando realmente eran dos hechos que habían coincidido en un lugar y en un tiempo, pero no tenían nada que ver. Luego se investigaba las razones del fallecimiento y no tenían nada que ver con la vacuna, no había ninguna relación causa-efecto. También falsas noticias que decían que las vacunas estaban causando las nuevas variantes de la enfermedad de COVID-19. Sabemos que el momento de vacunación, ¿no? Donde las campañas de vacunación se estaban desarrollando con mayor ímpetu, correspondían en muchos casos con esta circulación de nuevas variantes del coronavirus, entonces falsamente también se correlacionaban estas dos cosas. La realidad es que fue necesario salir a llenar ese vacío informativo, contar realmente qué eran las variantes, por qué se producían y de qué forma las vacunas podían ayudar a que haya menos transmisión del virus y a que haya menos variantes, nuevas variantes circulantes, y no que era al revés como decían las desinformaciones. Y también otras noticias falsas tenían que ver con la supuesta falta de efectividad de las vacunas, sobre todo al principio, cuando teníamos personas que se vacunaban y se infectaban. Hubo que salir a aclarar rápidamente que la vacuna tenía una alta efectividad para reducir los casos graves de COVID-19, todo lo que tenía que ver con hospitalizaciones y muertes, pero no así para evitar el contagio. Bueno, les comentaba que otra desinformación común sobre vacunas COVID-19 tenía que ver con los componentes dañinos como los metales o el grafeno. Esto es una desinformación que circuló muchísimo y también en formas de memes o parodias, donde las personas luego de vacunarse decían que quedaban imantadas y hacían pruebas o videos mostrando cómo se les pegaban objetos metálicos al brazo. No es una desinformación nueva, ya durante otras campañas de vacunación vimos cómo se afectaba el tema de los componentes de las vacunas cuando se hacía, por ejemplo, mención a el mercurio. Sabemos que es importante, entonces, en este sentido, comunicar a las personas efectivamente cuáles son los componentes de las vacunas, que no hay ningún componente que pueda ser peligroso para la salud. Y también en muchas ocasiones contar, por ejemplo, qué es el grafeno, ¿no? Había mucho desconocimiento sobre este material nuevo y por eso las personas llegaban a creer que realmente podía ser un componente de las vacunas y podía llegar a inmunizar a una persona, por más que la evidencia mostraba lo contrario. Otras de las desinformaciones comunes sobre vacunas tenía que ver con la inmunidad natural. Según estas desinformaciones, no era necesario vacunarse, era mejor entonces enfermarse y tener inmunidad natural por COVID-19. La realidad muestra que cada persona transcurre la enfermedad de una forma diferente y tener COVID para muchas puede representar gravedad, hospitalización, muerte y también efectos adversos a largo plazo o COVID largo, ¿no? Long COVID. Con lo cual fue necesario, a partir de los chequeos, salir a aclarar que la inmunidad que tienen que dan las vacunas es mucho más robusta que la inmunidad natural, y como siempre que los beneficios de vacunarse son mucho mayores a los potenciales riesgos. Ahora me gustaría dejarles algunos tips, algunos consejos para comunicar de forma responsable acerca de vacunación en general y también vacunación COVID-19 en particular. Sabemos que la información sobre las vacunas puede influenciar las decisiones de salud, por eso es muy importante que esta información sea clara, sea concisa y esté basada en la evidencia científica. Es mucho más fácilmente recordable y entendible cuando la información es fácil de procesar, con lo cual hay que tratar de evitar de todas formas los tecnicismos y también simplificar el lenguaje. Siempre que vamos a incluir una palabra desconocida, un tecnicismo, por ejemplo, hoy hablamos de las variantes, tenemos que tratar de explicarles a nuestra audiencia qué son las variantes o algún otro tecnicismo, palabra técnica que hayamos utilizado. No dejar lugar a interpretaciones o a la duda. También siempre, por supuesto, tratar de incluir fuentes que sean expertas, que sean fidedignas y que estén autorizadas, como puede ser la Organización Panamericana de la Salud, la Organización Mundial de la Salud, las autoridades sanitarias, también asociaciones científicas o académicas. Y por supuesto, siempre que ponemos un dato, remitirlo a la fuente. Es muy importante validar realmente las preocupaciones de las personas, las dudas, dar lugar al diálogo, a que se pueda generar con aquella persona que tenga dudas sobre las vacunas un diálogo basado en la empatía. En este sentido, es clave comunicar abiertamente cómo se investigaron las vacunas, las diferentes fases de los ensayos clínicos, cómo fue el esfuerzo sin precedentes de toda la comunidad científica para desarrollar en forma rápida vacunas que son efectivas y también que son seguras. No dar nada por sentado, ¿no? Explicar realmente cómo se hicieron los ensayos clínicos, cómo se testeó la seguridad, cómo sabemos que las vacunas son seguras, cómo actuaron y cómo actúan los organismos regulatorios de cada país y cómo también se monitorean los eventos adversos. En estos momentos, por ejemplo, hay muchas dudas de las personas con respecto a darse o no un refuerzo de la vacuna, o cada cuánto tendremos que vacunarnos contra la COVID-19. Entonces hay que tratar de llenar esos vacíos informativos con información confiable. Y también para que les llegue a aquellas personas que todavía no se aplicaron ningún refuerzo. No sé qué pasará en sus países, pero en la Argentina tenemos personas que se han vacunado, pero no han vuelto por su refuerzo de su vacuna. Esto es también muy importante, ustedes que tienen diálogo con periodistas, que siempre que nos enfrentamos a un estudio científico, nos hagamos una serie de preguntas, como por ejemplo, ¿quiénes son los autores de ese artículo científico? Si fue publicado en una revista científica que tiene revisión por pares. Si hay algunos expertos independientes que puedan analizar los resultados y que nos digan la relevancia de esos resultados. Hay que diferenciar apropiadamente si se trata de un estudio científico publicado en una revista científica o si se trata de un preprint, un estudio preliminar, ¿no? Durante la pandemia tuvimos un boom de preprint que se daban ya como información validada, cuando la realidad era que no era así. Y también hay que tener cuidado con las llamadas revistas depredadoras, revistas donde los científicos pagan por publicar sus investigaciones, revistas que no tienen revisión por pares y que es dudosa, digamos, su alcance y su reputación. También durante la pandemia vimos muchas notas periodísticas que contaban casos personales, ¿no? tal persona se vacunó y le pasó esto, tené cuidado. Bueno, es importante siempre tener en cuenta que la información no puede estar basada en casos aislados o en anécdotas personales, ¿no? La vacunación no es un proceso individual, es un proceso colectivo y hay que evitar llegar a conclusiones generales a partir de una historia personal. Y como antes decíamos, también cuando vamos a hablar sobre eventos adversos, diferenciar siempre causalidad de correlación y también contar claramente que los eventos que ocurren después de la vacunación no están necesariamente causados por ella. Esto es clave también, incluir mensajes claves y repetirlos a lo largo de nuestras comunicaciones, ¿sí? Por ejemplo, que las vacunas salvan vidas, que las vacunas son seguras y efectivas, que protegen a las personas más vulnerables, que son un derecho, que garantizan la equidad. Son algunos de los ejemplos de mensajes claves que podemos repetir en nuestras comunicaciones y que son muy valiosas. Después tenemos que ser muy responsables cuando presentamos, sobre todo figuras o porcentajes. El uso de la estadística sin el contexto adecuado puede crear falsas conclusiones. Les pido por un momento que se fijen en este ejemplo, perdón que está en español. Es un ejemplo con accidentes de tráfico, pero se puede realmente llevar a las vacunas. Si nosotros vemos la cantidad de personas que fallecieron, que llevaban o no cinturón, puedo rápidamente tener una conclusión errónea y decir, uy, fallecieron 110 personas que llevaban cinturón y 35 que no llevaban cinturón, y sacar la conclusión errónea de que murieron más personas que llevaban puesto el cinturón de seguridad. Bueno, la realidad es que esta es una falacia estadística que se conoce como paradoja de Simpson y que ocurre cuando nosotros analizamos en forma conjunta resultados cuando deberíamos estar analizando los subgrupos. Si nosotros analizamos los subgrupos nos damos cuenta que solo que fallecieron el 70% de las personas que no llevaban el cinturón de seguridad frente únicamente al 11% de las personas que sí llevaban el cinturón de seguridad. Traigo este ejemplo a colación porque una de las desinformaciones que más circularon tenían que ver con, al principio sobre todo de la campaña de vacunación contra el COVID, tenía que ver con que decían que había hospitalizadas más personas vacunadas que no vacunadas. Y esto se trataba de una falacia estadística, ¿verdad? Con esto también nosotros podemos mostrarle a nuestras audiencias que con los números se pueden engañar y hay que tener también mucho cuidado al tratamiento que hacemos de las estadísticas. Un poco lo que hablaba también Tania, con mostrar las estrategias, ¿no?, que se utilizan para engañar o lo que se denomina como pre-banking o inoculación preventiva. Es importante también contar historias, ¿no? Muchas veces entendemos el mundo a partir de las historias que nos cuentan. Podemos hablar sobre las campañas de vacunación, apelar al emocional, sin perder rigor y precisión. Puse allí algunos ejemplos de historias de este último tiempo que realmente me conmovieron. Perdón que la mayoría son en español, pero les voy a contar algunas de ellas. Por ejemplo, una de las historias que conocimos antes de la pandemia tenía que ver cómo en moto, en bote y hasta en carreta, un grupo de vacunadoras llevaban a cada rincón del país vacunas para chicos. En la Argentina tenemos un país muy extenso y con una geografía muy variada y muy difícil, a veces es muy difícil acercar las vacunas. Esta nota relataba el trabajo que hacían las vacunadoras para llegar con cada vacuna al interior del país. Y realmente era una historia muy bonita para conocer. También este ejemplo de Salud con Lupa en Perú, en primera persona, un periodista contó cómo era ser voluntario de una vacuna contra el coronavirus, de un ensayo, cómo era participar de un ensayo clínico. Y en este sentido era muy rico lo que él sentía y cómo lo relataba al participar de un momento que él lo vivía como histórico. Muchas veces no recordamos qué pasó con pandemias pasadas. Puse allí una historia que también me conmovió mucho, que se publicó en el diario El Mundo de España y que tenía que ver con la vida tras la poliomielitis, cómo era a una persona que había tenido secuelas por la pandemia de esta enfermedad, qué pensaba hoy de la pandemia de coronavirus, cómo había vivido la anterior pandemia de poliomielitis y cuál era el consejo que daba a las nuevas generaciones con respecto a la vacunación. Y bueno, y hay otros ejemplos que tienen que ver con cómo las vacunas cambiaron la historia de la humanidad y salvaron a la humanidad, o cómo enfermeras, vacunadoras lograron que algunas comunidades que no querían vacunarse cambien hábitos de salud. También es muy importante y me gusta hacer hincapié en este consejo de que las imágenes también comunican. Al utilizar fotografías o también imágenes para videos, tenemos que tener en cuenta que las imágenes negativas pueden predisponer a una persona a no vacunarse. Por eso hay que tratar de evitar imágenes, por ejemplo, que muestren grandes agujas cargadas de líquidos de colores que no sabemos muy bien de qué son, imágenes de chicos llorando o sufriendo. Bueno, esas imágenes no son las recomendadas, ¿no? Casi siempre lo que tratamos, y en ese sentido ustedes también, si tienen contacto con los periodistas, es de que utilicen las imágenes más reales posibles de campañas de vacunación que se estén realizando. Y en ese sentido no quería olvidarme también decir que muchas veces personas que he llegado a buenas historias para contar que tengan que ver con vacunación a través de personas que trabajan en contacto con ministerios de salud o que trabajan en la campaña, que están involucrados activamente en las campañas de vacunación. Como periodista muchas veces esas personas son quienes me acercan historias interesantes para contar, con lo cual creo que también ustedes pueden hacer mucho en ese sentido. Y quiero recomendarles esta guía para verificar información sobre 2019 que está destinada a periodistas para que ustedes puedan compartir, leer y también compartir. Es esta guía que creamos desde Chequeado y la Organización Panamericana de la Salud, también con material de la Sociedad Argentina de Vacunología y Epidemiología, de la que formo parte, y también otra organización de verificación internacional como Expert Draft. Esta guía está disponible, seguramente Tania va a poder compartir con ustedes el link para descargarla, y muchos de los conceptos que resumí en esta presentación están abordados de forma más extendida en esta guía que les recomiendo. Muchas gracias.
So yes, thanks everyone. The video I'm going to show and the pictures I'm going to show is, I want everyone here to understand that anti-vaxxers have been around since vaccines have been around. This isn't something new. Public outrage, quote unquote, for vaccines isn't something new. Every time there is a new campaign, every time there's a new vaccine, these people pop up and they're like, oh, they're coming for us. So I'm going to show you a quick video. It's like 3 minutes that talks a bit about this history of anti-vaxxers. And then I'm going to show you some historical photos as well from anti-vaxxer movements from back in the 1800s.
We've been hearing a lot about anti-vaxxers in the news lately, but they've been around since the beginning of vaccines. Vaccines date back to the research of Edward Jenner, a doctor who was working in rural Britain in the 1700s. He noticed that on the farm, the milkmaids didn't get smallpox in the way everyone else around him seemed to. So, one by one, he started scraping pus from sick cows into the skin of his family members, and miraculously, they didn't get sick. His discovery led to the smallpox vaccine and later the world's first and only infectious disease eradication.
This child has what we call active immunity. He has acquired this active immunity by actually having the disease. Fortunately, there's a safer way to get immunity. This is through vaccination.
Edward Jenner was basically ostracized from his community. People thought it was disgusting that he would inject his family with pathogens from a sick animal. Fast forward to today, and the same kinds of concerns continue.
We do not need that many vaccines.
People overly generalize about them as if they're only great.
Doctors have to ask brand new parents to give otherwise healthy babies dozens of needles based on the promise that they'll avoid some future abstract disease. One discredited paper made many parents think that there was a link between the measles, mumps, rubella vaccine and autism.
The parents understand it, they get it, because they've lived it.
The message from the BMJ could not be clearer or more shocking. Wakefield research, they contend, has been a fraud.
And we have other anti-vaxxers today who aren't only worried about autism. There are the delayers like Rand Paul.
We sometimes give 5 and 6 vaccines all at one time. I chose to have mine delayed.
There are deniers of all stripes. They're the Orthodox Jews in Brooklyn. They're the parents of children with medical conditions who have to opt out. There are even unvaccinated kids visiting Disneyland. The majority of last year's massive uptick in measles cases actually involved the Amish of Ohio. More than 350 people there were infected by one man who had traveled to the Philippines. These outbreaks of vaccine-preventable diseases in the US typically happen just like that. An unimmunized person travels to a place where one of these diseases is circulating and then returns to a community with other similarly unimmunized people. And boom, we don't remember what measles or polio or hepatitis B looked like and felt like.
These vaccines work so well that the memory of these diseases has faded.
Viruses and bacteria don't know any borders. All it takes is a single traveler to spark an outbreak, even in the happiest place on earth.
Yeah, so just to give context, that video is from 2015. It's not even from after COVID. You know, again, these are people that have been there, will be there, not now, but in a long time. And if you can pass the presentation, we can see some of the photos. I'll pass it, just you can show it. So this is actually from the turn of the century, so from the 19th century, and it was a anti-vaxxer campaign in England. And as you can see, very much fear-mongering, very much making parents feel like they shouldn't vaccinate their children. This is from 1902. I believe this is New York City. There was the Anti-Vaccine League of America from 1902, and they were protesting mandatory vaccination at that time for smallpox when, you know, the smallpox eradication and all of that was trying to happen. Look at this, what vaccination has really done, all these pamphlets, all these people demonstrating. It looks very much like now, right? Like the type of same antics and tactics that they've been using. This is from 1885. The same thing, this is that concept that clean water and cleanliness and, you know, washing your hands and living a healthy diet or a healthy lifestyle can replace vaccines. It's a very common anti-vaccine argument, but this has been around for forever, and it doesn't, of course, we all know that it doesn't just prevent, it doesn't help preventing vaccine preventable diseases. And this is from the beginning. This is in France, I believe in the 1800s when they were trying to vaccinate against smallpox. You can see the children very scared running away from the ginormous needle of these people that look like witches and wizards. I'm not even sure. And then there's what I guess is the smallpox monster coming, you know, carrying them and taking them to these afraid laymen. Same here. This one talks about how, they're trying to get from the cow the vaccine that then they will take to the people. This is also in France in the 1800s. And this one is that caricature that they were talking about. This is Edward Jenner, the inventor of vaccines, or the father of vaccination and immunization. And after he's giving in the vaccine, the people are, I don't know, they're turning into cows, or a cow is springing up from that man's arm, and you can see them like, I think that's a cow coming out of his leg. So it's just very much, that's it, very much like fear mongering, very much the same tactics, just to say that don't feel despair. This has happened before. We will get through it, and it will happen again. We just have to be prepared for when it happens again, and when we are in the same situation where we're introducing a new vaccine into a country or there's a new epidemic. The same thing, from what I hear, happened back in 2009 when there was the H1N1 pandemic. People were very fearful of getting their flu shot, their pandemic flu shot at the time. So it's something that is reoccurring just because that's how we are. We forget. We have collective amnesia. We haven't lived it, so we don't think it applies to us. And with that, we're going to start talking about crisis communication for vaccine safety. And the thing about crisis communication, I'm going to switch mics now. Okay. So the thing about, can you hear me? Okay. I always have issues with my technology. I don't know why. You think I'm better at this. So the issue with vaccine safety is vaccine safety keeps being reported as probably the #1 cause as to why people don't get vaccinated. They're worried about the side effects. They're worried about what the vaccine can do to them and their family, not just immediately, but in the future, right? Like we've heard these myths about vaccine making you infertile, vaccine making you have cancer in the future. We know that there are some adverse events and we know that there are some side effects, but usually the risk of getting the disease is much higher than getting vaccinated. But what this presentation is going to be about is how can us from the communication side be prepared for when these crises occur. And this is not just for COVID-19 vaccines. These are for the vaccines in the regular program as well. And we're going to be talking a little bit about when the different scenarios and what kind of response to do or to, roll out in depending on the scenario. So like I said, quickly, what are the objectives? So we're going to talk about the phases of crisis management. This isn't reputational crisis management. This is specifically for vaccine safety related events. So an ISAVI or a programmatic error, for example, like the nurse didn't really know how to give the vaccine and it resulted in a welt in the kid's arm, things like that. The determinants of vaccination, we've been hearing a lot about what these determinants are, how do people reach the vaccine decision, what influences our behavior, how do we reach these decisions, and a bit about the risk perception gap. The key actions and actors, this is when we come specifically to what do we need to do to respond to a vaccine crisis, who to engage and how to engage and why do we do this. Very practical tips. We have a guide. We're hoping it's actually being rolled out by the end of this month. All of this is in a course online in our virtual campus for public health. So if you ever need a refresher, you can go back up there. The guide is there. It has some resources that you can look at and see how you can have this plan. So risk perception and the decision to vaccinate. So when it comes to risk perception, and it's up here, right? People will make the decision to get vaccinated if they see that the risk of the disease is higher than the risk that comes with getting vaccinated. If they don't have this risk for the disease, which has been happening lately with our generation that are becoming parents, we haven't seen polio, we haven't seen measles, we haven't seen neonatal tetanus, we don't really see rotavirus disease out there. So we don't have this latent threat to our children with this disease. Therefore, we choose not to get vaccinated because why would I do that, right? This isn't something that affects me or my community. So when the risk is not there, it creates this gap between choosing to get vaccinated and choosing to either delay or to not vaccinate at all. And these are called the mechanisms of how people arrive to decisions. They're also called heuristics. So we have the affective heuristic. people tend to be guided by their emotions and how do they feel about it, because that is how we respond to risk. People respond to risk with emotions: fear, happiness, indecision, all of that. So their emotions make them make decisions and it helps them act. The safety effect, well, as human beings, we focus more on losses than in gains. What will I lose from doing this than what will I gain from it? The confirmation bias, we are much more likely to seek out sources that confirm what we believe than to seek out sources that will speak against of what we believe. So if I'm on Google, if I'm already an anti-vaxxer, I'll be looking for sources that say, yes, you're right, instead of saying, hey, maybe you might not be right. What about look at this? So that is something very important to keep in mind, that people will seek out information that confirms what they already believe. And we do this also for us who believe in vaccines, right? We're not gonna be looking at anti-vax literature or any publication. We're gonna be looking at things that confirm what we wanna say to communicate it. The availability heuristic, this is solely based on the fact that what comes to my mind the fastest, what I've just seen, what I've just heard, is what I'm going to choose to help me inform my decision. I don't know if that makes sense. If you have any questions later, we can talk about it. And anchoring heuristics, we use things that are familiar to us. Those are called the anchors to make decisions. So things that we've seen before, things that we know, people that we know, their opinions, that becomes part of our decision-making process. And why is this important for us to understand? It's because us as public health people right here, health authorities and healthcare workers, don't make our decisions the same way the public makes them. We make decisions based on information that we've gathered through our years of studying, through all the courses that we've seen in university or in our graduate studies. We use the evidence and the data that we have in front of us as public health officials to make decisions. We use the training that we've received and the research that maybe ourselves have done or that others have done to inform our decision-making process and why we're doing what we're doing. The public, on the other side, uses, of course, they use some information, but they use their emotions, how things make them feel, and the experiences that they themselves have gone through and their families and friends and their communities, and the biases I just spoke to make decisions. So there is this gap in the middle of how the decision process between of what we're doing and us public health officials and the public is doing. And our responsibility is to fill this gap right here through effective, clear, transparent communication, through community engagement, through risk communication, crisis communication, to make sure that they understand the message that we are trying to give. I think I said this yesterday, but the responsibility for them to understand the message lies with us, not with them. It is our responsibility to make sure that our messages are clear and that they're understanding what we're trying to say. We can't just say, oh, well, if you don't know how to interpret it, then I can't help you with that. That's not right. We have to make sure that it is presented in a way that they can understand it. And of course, that's why we need to adapt the language, adapt the formats, make it culturally relevant, use channels that are relevant to that population or the specific target group. And why do we do that? Because the main goal for crisis communication overall is to either build, maintain, or restore trust in the vaccines themselves, the vaccination process, and the authorities delivering, meaning all of you, the EPI program, the vaccinators, all of that. And these are some of the goals that, it's basically a summary of this. I'm not gonna stop on them, but these are the goals for crisis communication. And how do we go about building a crisis communication plan? So obviously the first phase is preparation. We've talked about this. This isn't just for crisis communication. This is for vaccine demand plans that this will feed into. This is for risk communications and RCCU. You have to be prepared before a health emergency happens, a crisis for vaccine safety happens. You can't be doing all of these steps right here and these steps at the same time when something is already happening, because you won't have the time. You just simply won't have the time. Someone was talking yesterday about how they've been working 24/7, leaving their personal lives while we still have personal lives. Our personal lives haven't stopped with the pandemic, but our work has doubled. So we have to be prepared, advocate for having this preparedness before something bad happens. And we know now that several things can happen at the same time. Look at what's happening in our region, right? We have the COVID pandemic still going on. We have monkeypox now going on. We also have cholera in Haiti going on. We also have the risk of introduction of vaccine preventable diseases going on. So it's like 4 different crises in one. So if we're not prepared for it, we won't be able to answer even one. And that's what I think the key message here from this whole workshop would be: to be prepared. Try to be prepared. Try to have mechanisms in place that will help you respond to when a health emergency or a crisis comes on. The second is an implementation phase. I'll talk about all of these. And of course, our lovely evaluation phase, which, like I said before, we all tend to just sweep it under the rug and move on because we don't have time, but it's very important. So what is the preparation phase? The number one is get to know your evidence. We've talked about this with infodemic management. We talked about this with risk communications. You have to know what's happening out there for you to formulate any kind of plan, whether it is crisis comms, whether it is RCCE. What is happening with your public, with their perceptions? How are the behavioral and social drivers of vaccination impacting what's happening? And this is very important because in crisis communication, when you're monitoring what's happening, will help you develop your plan. Of course, it will happen, if it will change if there's a crisis, but you already at least have a baseline of what is going on out there. The second one, I think Tanya just talked about this again too, and I don't think we can emphasize it enough. Have your stakeholders ready. Have processes ready in place that will help you advance response when you're in a crisis. You can't be calling people to the table when a crisis is already happening. You don't have those relationships built with the community. You don't have the relationships built with the Ministry of Education, with the Ministry of Transportation. You don't have that. So a crisis will make it much more difficult for you to respond in a timely, consistent manner if you have had these, previous meetings, previous work groups already in place. Establish respond mechanisms, I just talked about that. And this right here is the part of RCC that I like the most, which is continuously informing the public so we can do this whole pre-bunking before debunking, fill their information gaps before a crisis comes. Make sure that they have like a protective shield against misinformation and against misinformation that will spread like wildfire during crises. And at the end, if you haven't gotten out of the preparation phase, if there hasn't been any crisis in your country, try to monitor your plan and evaluate it so you know if there's something you have to think about, that you forgot a key actor, who could I have included, that a crisis didn't happen. So how do we make this better before a crisis happens? There we go. So who are your key actors that you can, and how do you identify them, right? So who is an important supporter? Who is already on your side? Who have you worked with in the past that has helped you achieve your goals? Always start there. Who is a big supporter of immunization? Who is a person that has helped you fund things before? Who it is, right? Then you would think about who are the most reliable sources of information for your public. Is it a influencer? Is it your NITAC members? Is it who can help you communicate the message better? You have to have focal points in a lot of your partners, because if there isn't a focal point, the communication just won't be there. We know that if you don't have a person that you know and you can talk to, things will just fall in the cracks, right? The emails won't get answered, calls will get answered. So think about who would your focal point be. Think about some of the questions that the media might want to know specifically to vaccine-related crisis events. I'm sure you already have the experience that will help you think of some of these questions that you've gotten in the past. I'm sure your EPI managers are a wonderful source of things that they've been asked for by the press before, so you can start thinking about some of these questions and how you would have answered them differently to have a better impact. The consequence here, this is very important. This is, what do you think could go bad? Also prepare for the bad. We like to be prepared for the good, but prepare for the bad so you know how you would handle it in case something goes awry. And then here is who could be an opposition force. Is it the anti-vax groups? Is it the political opposition? We've seen a lot of that in COVID, right? Like where the government's saying one thing and the opposition leader who's trying to become president next term is like, but me, right? So think about who could be a hindrance to your messages. Is it an important religious leader who doesn't believe in vaccination? Who in your, all of this has to be thought at the local level very much. You are the experts in your countries and you know how you will be able to feel all of this. And like I said before, it is very important to build robust relationships before a crisis happens, before a health emergency. That way, when it happens, you have the mechanisms in place. So, mechanisms. Once you have these mechanisms, they all have to speak at the same tune. First, you have to train your spokespeople, whoever is going to go out there to talk to the public, to the press. You can't send, whether it is your Ministry of Health, whether it is whoever, they can't go out there without having been trained on the messages, on how to respond to media questions, how to keep their cool when they're being asked problematic things. They have to be trained before you send them out there. If they go out there and they don't respond in a way that invokes trust, it can make a lot of damage, and we've seen it. Not only to the program, but to the vaccines themselves. So it's very important that you train your spokespeople and whoever from all this entire mechanism, whoever, all of them, that they are there, they need to be trained on how to speak to the public and the media. Prepare your messages. This is important because these messages will later help you. You will just adjust them when the crisis happens. So have some messages prepared on the safety of the vaccine, specifically since we're talking about vaccine safety. Have some messages that already, talk about the risk of vaccination. Of course there is, but also they talk about the benefits of vaccination, just so when a crisis happens, you're not working from zero. It's good to have like a set of messages that you would roll out in case anything happens. Understanding the media. I know that you can't really see this, but it says natural partners right there. I'm so sorry about that, Gray. Understand how the press work. Us communicators, we know how our press works. Some of us have worked as journalists or as correspondents in our previous before public health life. So understand how do they work. What are some of the radio stations? What are some of the TV stations that are more friendly? What are some of that are not as friendly? That might be more problematic. How do they work, and how we can make them our partners? How we can work with the media to ensure that in their role as informants of the public, they can help us carry our message. The other one, inform the public, build resilience. We've talked about this whole pre-bunking before debunking, and then again, monitor the events. Tanya was talking about social media monitoring. I really like about social media monitoring is that it can pick up safety signals. People can start reporting adverse events. Of course, not all of them are going to be true. Of course, not all of them are going to be something worth looking into. But if you have, let's say in a country where there's 100,000 people, right, in the whole country, and you see 20,000 tweets coming up about a certain thing, that's something might work, it might be worth looking at that. So monitoring events in the media and the public perception right here is very important. Okay, so how do we respond to an event? The first step is understanding the event, who, what, where, and why. This is combined work between us communicators and our EPI managers and whoever is responsible for savvy surveillance in the country. I know the vaccine safety team has been working with a lot of countries in the Caribbean to get their savvy surveillance systems up and running. It has started with COVID, of course, but I think it's something that will continue to happen just because of how important vaccine safety is, not just for you, but for the public. How do you classify an event? So what are the different events that could undermine the trust in the public? So you have an savvy vaccination campaign, or other changes in a program. Have you decided to introduce a new vaccine? Have you decided to stop using, the polio OPV and you decided to introduce IPV in your schedule? I don't know, things like that. All of that can have vaccine safety related events that you have to monitor, and you have to make sure that you know how to classify them. And what is the impact? Is it low, medium, high? Did it gather a lot of knowledge in the press, or people are just like, well, we don't really worry about it, so how, and then we'll talk about what to do on each of these. No, if it's a low impact, I wouldn't do anything about it. You just move on and wait to see what happens, right? But if you know that this is something is going to have a high impact, then you have to act. And the last one is the communication response. So you start preparing, you have your plans, and how do you move forward from you classify the event, you classify the impact, and you're like, yes, we need to do something about it. How would you go about it? So there are 3 events that when it comes to vaccine safety, we chose to focus on. The first one is on ESAVI, events supposedly attributed to vaccination or immunization. For those of us who didn't know who ESAVI was until COVID-19, me. So what is it? Is an unexpected health situation following immunization. It could be, from a really high fever to a rash, something basically out of the norm. That doesn't mean that the event was caused by the vaccine. That is the number one thing that you have to remember about ESAVIs. It is supposedly, attributed to vaccination. Usually what happens, and maybe the EPI managers can help me be here when it comes to ESAVI case investigation, is there's a whole team that gets together, they review the evidence, they investigate the event, and then after that they will produce a report that says, yes, this was caused by the vaccine, no, this is a unrelated event. ESAVIs can have low, medium, and high impact. It will depend on the seriousness of the event. It will depend on whether or not the media has picked it up and has become viral in the country. It will depend on, did someone die after getting vaccinated? Is it just a small rash on a little kid? What is it? So depending on how serious the event is, it will have an impact level. Now, what are the key actions that you need to take into account when you're classifying an ESAVI? Is, of course, you be prepared. You will have your messages already in place. You can adapt. You will have your spokespeople already trained. You have to expect anxiety and public insecurity. No one likes things that come out of nowhere, and usually that's what happens with ESAVIs, right? And then keep monitoring what's happening in transparent communication. That is very key. You have to let the public know what you know and what you don't know. If you don't know something, say, we don't know yet, we're investigating, or we haven't reached a conclusion. Maybe the minister is saying, right, I have a whole team of people that are looking into this, and once we know, we will let you know, but as of right now, we don't. The other one is, like I said, a campaign or a change in the immunization program, like introducing a vaccine, replacing a vaccine, vaccination campaigns, or maybe we've seen with COVID-19, there were a couple of recalls that happened in other countries in the world, and that kind of affected us, right? Like there was one, I believe, in Japan, there was one in South Korea, there was one in France. So several recalls around the world that kind of impacted our programs. So all of these, it depends, again, on the virality, on if the press picks it up, on the seriousness of the event. The thing is, when these happen, it's very important to explain the reason for the changes, inform the public, why are we changing the vaccination schedule? Why are we using this vaccines versus the other vaccine? Like with polio, you can explain why the country decided to introduce IPV and get rid of OPV, right? Like why is the scientific reason behind that? Why, as experts, we've made the recommendation. Usually, recalls or temporary suspension of vaccinations are precautionary measures. Most of the time is the manufacturing figuring out that they made a mistake in the manufacturing process, and they're like, oh, we have to suspend it until we'll make sure everything's fine, but that will usually happen, and you also have to clarify what you know there and what you don't know there. And well, here it says, because this is for everything, but pandemics and vaccines have to be considered new vaccines. So either COVID now is a coronavirus, or like I said, in the H1N1 pandemic in 2009, which is a pandemic flu. And the last one, which is the video I was just telling you about, publications or debate on vaccination. So could it be fake scientific publication? Could it be rumors? Could it be a critical article or a critical scientific study? These ones are trickier because not everything will need a response. It will just depend on the impact that you think it's having on public opinion. That's just the formula specific for publications. and debate. What is the impact that it's having on our publication? There, like it says here, is very common. You've seen in that video, it's been happening for many, many years. Every so many years, it seems like they pop up and they're like, they have some anti-vaccine message. Like it says here, unreliable scientific research is not infrequent. Sometimes they don't generate any public reaction or any attention. Sometimes they do, so it will depend on how viral is going in our public for us to say anything about it. Okay, so those are the events right there. This is how do we respond to the crisis itself. So once we've had our preparation, we've decided that an event does require a response from us, from the health promotion, from the public relations, from the EPI program. How do we go about it? Okay, so first, this you will gather your response group, all the relevant key stakeholders that you've been working with in the past to create your plan, gather them, put them together. How, meet regularly, keep them informed. It's good to have them inform you, like it says here, and you inform them. They might be picking up on things that you haven't heard. They might know things that you don't know. So it's good to have this two-way communication between you and between them. And this will also ensure that you all have the same relevant information. So if there's any requests from the media, if there's any public statements that need to be given, you are all aware of everything and no one can go out and say, oh, I was working with them and they didn't tell me about this. And it can happen. So who's your key audiences? Who was the person affected the most by the crisis? Who could be your influencer? If it's someone in a specific community, is there a community leader that you can go talk to and they can be your bridge to that community? If it's, an Isavi and an indigenous population, go to the leader of that community. Who can help you make the bridge between you and the specific population group? And who are some other groups that can influence the situation? Is it an NGO that's already been working on that with that community? Is it a famous person? We know, famous persons can be problematic, but maybe they can help you carry the message. You don't know. Define your goals. What is your goal? And what are your objectives? And then this is the part where you would take the messages that you've already been building, that everyone has been hearing this whole time, and you will adapt them specifically and tailor them for answering this specific situation, whether it's an ISAVI or a change in the program. Very important that you include risk-benefit communication. Try to increase the risk of the disease so the risk of taking the vaccines doesn't become higher in their minds. Your channels, of course, us as communicators, we know what channels work for different kind of people, right? If we're trying to reach younger audience, maybe we wouldn't focus on Facebook so much if we're putting out their social media messages. If we will do TikTok, or if it's a rural community that they don't have access to TV, we're not going to make TV ads. We're going to do radio and see if that radio reaches them, right? Or written pamphlets, or whatever it is that you need to do and has worked in your key audience and who you're trying to get the message at. The last one is prepare your spokespeople. This is less prepared because that you should have done this in the previous phase. This is more of them understanding the situation and understanding the messages that you've just tailored for them to know what they have to say. The media's agenda, they always have an agenda. We all have an agenda. Their agenda is to get more views, probably, and then get more people to buy ads in their channels and their TV stations. Our agenda, hopefully, is, keep our population healthy and safe. So you have to understand who's going to be interviewing you, what channels are going to be using. If you're having like a public speaking forum, let's say with journalists, know who those journalists are. We know from the Ministry of Health now and from this past 2 years, there are some journalists that are more friendly to us. And there are some journalists who are not afraid of just saying whatever in those public forums, and they can put us in a hot place. So understand that that person's going to be there, and make sure your spokesperson is prepared to answer some of these hot topic questions. You can't just send them out and say swim. You have to give them a life vest and a bit of a boat so they can do it. And that is your messages, and that's your preparation. Inform the public. This you will be doing through your media campaigns, your health promotion campaigns, your materials that you will put out there with the messages that ensure that their risk perception is addressed. Make sure that your communication is evidence informed. I really don't need to tell you this because these are all the things you know as communicators and working in the field of communication, you know that. And then this is very important. All stakeholders speak with one voice. So if you keep them informed, they've kept you informed, you should all be saying the exact same thing. It won't look good if people that are supposed to be in a partnership go out to the public and to the media and they say contradictory things. It's going to create a bigger problem than what it would be if you all go out with the same voice, the same messages. And also keep your media informed, right? Maintain regular contact with them, share information, share them pamphlets, share them talking points, share them speeches, or whatever it is that they need to do to make their job not easier, but make sure that their message is better and it's in line with what you're trying to say and what you're reporting when it comes to a vaccine safety crisis. Monitoring and continuing the response. Once you've done all of these, you want to keep monitoring the public and their opinion, through social media. Now, everything we say in the TV, on the radio, eventually ends up on Twitter or on Facebook. We know that. They'll take pictures of it. They'll take recordings. They'll even quote tweet you. So monitor what's happening in all of this to make sure that your message is getting across, or if you need to change the message. It might be that what you're saying, it's not really well understood, it's too technical, and people are not getting what you're trying to say, so then you would have to address what you're doing, the channels you're using to get through them. These, again, you establish mechanisms to capture this data. All of this would have been done at the beginning, because when you're responding to a crisis, it's not time to do that. And again, work with the media. I keep saying in this whole, because this is part of a guide, we keep saying the media is your partner. They're our natural partners. They also have a role to play. So the better relationships we can build with them, the easier our job will be. Your communication has to be active. It has to be proactive, and is always tailored to the needs and concerns of the people that you're trying to get to. Once your crisis has happened, once, the media will die down and then they moved on to the next big thing, try to evaluate your plans and try to evaluate your response. It's good to have some introspective and look at what we've been doing. Did your coordinating with your stakeholders work? Is there someone that was more of a hindrance than an enabler? Do you need to replace, not that person, but do you need to replace that role? Do you need to ask someone that you didn't think you were going to need that role and you forgot about it, and then when you were in the middle of it, you were like, yes, I need someone to do this, right? Evaluate your response to the media. How was it? Did you have a good response? What could you have done better? Share your lessons learned and practices. I've said this before, other countries can learn from what you're doing and the experiences you've had and how you've gone about responding to a crisis, and they can tailor what you did and implement it in their country, hopefully. That's the whole idea of sharing lessons learned. And of course, make any changes that you want to make to your plan. What do you think could make it better? Now, some really key messages. These 3 next slides are going to be key messages just about vaccine safety, a savvy communication, and then what are the goals. So it is very important that you establish coordinated mechanisms that are rapid and effective. Someone was talking about red tape. Believe me, I know red tape. I don't think there's more red tape than in an international organization. You can believe me that. Lisa's laughing, and it's true. There's tons of red tape, and you know that it is there. So be prepared to have something that in a crisis doesn't have to go through all the red tape. It can be easier, create a group that will have the decision-making level that you need them to have to get things moving quickly. Because otherwise, you just stuck in this red tape. And while the word is moving forward and the world is advancing and there's rumors going on, you're just still waiting for that one approval through that one email from that one person. And you're still on your email like, please respond to me. I need to get this out right now, So make sure that you have these mechanisms in place. When we have vaccination in risk groups, it increases a coincidental event. It increases the chances of having an ESAVI or a programmatic malfunction or someone leaving the vaccine out for too long and then giving it to people. It just happens. Human error happens, and it happens to everyone, and it happens to all of us. Of course, there's always new concerns when it comes to a new vaccine. We've seen that it's been happening since the 1800s, since vaccines were created. These anti-vaxxer groups are going to come out, these concerns from people on the safety of the vaccines, that it wasn't properly tested, that it took too long or too short to be developed. They are there, and it will happen. You also have an increased interest and media focus in the vaccine program. We're seeing it now. We saw it with COVID. It was like no one cared about vaccines before, not that much. And then COVID-19 came and it was like the only thing we heard about for weeks. I work in public health and I got home and I turned everything off. I couldn't hear the word COVID vaccine anymore. It was just too much. And I'm sure all of you, were in the same boat. It was just too much. So it just increases the attention that the public has on us as public health professionals, and then the topic is just like right there, trending topic every day. And this is also very important, especially here in the Caribbean, since you all have close-knit communities and you have a lot of relationship with other islands and with the US. What happens in a country can affect what happens in another country. I'm seeing a lot of this in countries like Bolivia and Argentina in South America. What's happening in Argentina is having a big impact in Bolivia. Whether it is anti-vax groups that are growing up there, or is it cases of new disease? And also with the diseases, right? They travel, information also travels. ESAVI communication. So the one thing about ESAVI communication is that it is very important to communicate the information both correctly and in a calm manner. You're in the middle of the crisis, but you have to stay calm and you have to show a sense of this is someone I can trust. This is someone that in a crisis will remain in all their senses and is thinking with their entire head and all their capabilities. They should know that the health personnel and you as health authorities, the public, they should know that you care about them and that you're worried that this happened and you're worried for the safety of other people. So you're responding in a manner that shows them that empathy, that warmthness, that human warmthness, and then you will keep them informed, whatever it is. And right here in yellow, I hope you can see, is never advance the conclusions of an ESAVI investigation. Don't report it to the public. Don't report any preliminary results. Report once it's done. Because if it changes, we've seen it with COVID, if it changes something and then you're saying something different, they're gonna be like, oh, you don't know anything. You told me yesterday it was blue, now it's yellow. What is going on? You're trying to get to us, you're trying to blah, 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 all of that. So just report what you know and report what you don't know. And once the investigation is final and your experts have said, yes, it was a, vaccine-related death, or no, it wasn't, then you can say it was not. And these things take time, and I know it's hard, but that's why you have to say, we don't know. We're investigating, we will tell you once it's done. All of this I just talked about. I guess from here, this two right here at the bottom. Adverse events do not mean the vaccines are unsafe. They happen. We know they happen. They've been happening. They will continue to happen. That doesn't mean they're vaccine related. That doesn't mean that the vaccines are unsafe. So this is very important to keep in mind when we're communicating. This is an important message that the public needs to know and needs to understand. In working with healthcare workers, we've talked about our relationship with healthcare workers. We talked about our relationships with practitioners, with pediatricians, with other health professions. They are very important, especially in ESAVI communication. Hopefully your outreach sessions and hopefully your relationships that you've built with these people have been done before the crisis and not during. My goodness. Oh. There we go. So, responding to hesitant groups and anti-vaxxers. We've seen anti-vaxxers are here to stay. We've seen they've been staying. They're very active on social media. They are always, seeking attention. They're very loud. They use these fear-monger antics. We've talked about this. They're our nemesis, we know. You have to continue to focus on the vaccine, the safety of the vaccines, and the benefit of the vaccines. You can't Tanya was saying, you can't engage in this war with these people. It's just not, what it does is amplify the message that they are trying to communicate, right? As much as you're trying to dissipate the message, if you give them a platform, it will be much worse. And the more we talk about vaccine hesitancy, it creates a social norm. How do I explain this? People love to follow. We love to follow the latest hair trend. We love to follow the latest shoe trend, latest clothes trend, the latest TikTok dance. We are social norm people. We want to do what others are doing. So if we see the vaccine hesitancy is the norm, more people are going to say, well, they're not getting vaccinated. I wonder why. Maybe I shouldn't. Do you know what I mean? So if we try to make vaccination the positive social norm where everyone is vaccinating, people might follow because we like to follow. That's just what it is. Why do we follow celebrities on social media? Because we kind of want to be them, right? Like we want to do what they're doing. We want to get what they're getting. We want to buy the houses that they're having. So just try to make it that vaccination is the cool thing. I know it's not that cool, but try to make it. Focus on, invest in training on your healthcare workers. Trust building principles and communications are very essential when you're talking about crisis, transparency, sincerity, clarity, competence, always with your messages, with your spokespeople. Following these 4 are very necessary. People want to know that they can trust you, that you're competent, and what you're saying is actually the sound scientific research. Focus on risk and trust, stick to it. Public encounters with vaccine deniers. We actually just published a guide. I will also include it in the resources on the steps you have to follow if you're ever requested to appear on a morning show with a vaccine denier. How would you go about going on that interview? The one thing about going in interviews with vaccine deniers is that you cannot go unprepared. People that haven't been trained on how to be a good spokespeople and people who aren't 100% knowledgeable of what they're going to say, it's actually going to create more problems if you go on this forum than if you don't go. Because you can make more damage to yourself and to the program and to trust if you go and engage with these deniers without having the experience and the knowledge and the training for doing so. Tailor your message to your audience and always communicate with one voice and coordinate with key stakeholders. So this is just a bit of overall messages of this whole presentation. And lastly, be prepared for a crisis. They will happen. We have seen this. The EPI managers can tell you crises happen all the time. There's all the time something or other going on. So be prepared for it from the communication side. What can you do to make sure that when it happens, you are ready? The number one objective to this is to build, keep, or rebuild trust in the program, in the vaccines, in yourselves as health authorities, in your healthcare workers as part of the EPI, and in immunization. And these are the 2 resources that I was talking about. I'll add the other one. This one is a very practical guidance on how would you go about creating your plan for crisis communication. It has some really cool annexes, like how do you build messages, an annex on the frequent questions that news people will ask the expert, some of the tactics that they use and how you can work around them, some extra resources. So it's a very nice practical guide. This is specifically for healthcare workers. It talks about the heuristics. It talks about how people want their answers, or some of the questions that they have, and how you as a healthcare worker can answer questions from the public in a way that makes them feel heard and makes them feel known that you're there for them and for their concerns. And like I said, we have 2 courses about to come out. It's been a while, but hopefully soon. And now we have some questions for you to answer. So I hope you've been paying attention. So if, I don't know, someone wants to raise their hand and answer, or you can all just, in unison, you can just give me the answer. So what is the main communications goal when responding to a vaccine crisis? Choose from the following. Number 4, that's right, build, maintain, or restore trust. Vaccine crisis can do horrible things to our program. They can undermine trust, all of this, right? Maintaining trust is the number 1 goal that you want to have when you're responding to a vaccine safety crisis related event, 100%. Next is how do health professionals assess risk. Like, what do they use? What is it based on? And if you want, I'll add what's the difference between people and health professionals when they're coming to assessing risk and making health-related decisions. I don't know if someone wants to answer or so evidence. And people do it by their emotions or things that, you know, they're familiar with and how things make them feel. So it's our job to close that risk gap. It was that nice presentation that had the gap. We have to close the gap with effective communication. This, we already said that. Oh, that's our, what's that? No, that's our case study. Okay, so here, what are the, look, I just gave you the answer. Cheat sheet. Okay, so what is step number 3 in responding to a vaccine crisis from the COMS part? There are other steps for the EPI managers, of course, but this is for the COMS part. Which one? 1, 2, 3, or 4? Yes, I don't know who said it, but yes, classify the impact. That's right. If the impact is low, you do nothing about it. You forget about it. You move on. If it's medium, assess if it's something that's worth you taking a look into and developing a whole COMS response. If it's high, of course, you have to act. You can't just leave it alone. It will create a whole monster on its own. And there we go. Okay, so I have a really quick case study. I don't know if maybe some of the EPI managers have been on the workshops that the vaccine safety team have done. I don't know if the I don't think you were included in this. So it'll be just a quick, I'll read you through this case study and then we'll answer some questions together. So it says, during a vaccination campaign to vaccinate health workers in country A, you, the Minister of Health or the EPI, received a report that a health worker has died just days after receiving his jab. Obviously, this could have a high impact, right? The case definition, he was male, he was 64, a healthcare worker, but he also had a bunch of other comorbidities, right? Hypertension, myocardial infarction 6 months ago, so he had already had a heart attack a while ago. And you are part of the National Communication Task Force, so how are you gonna respond to this event? And, you know, breaking news, it was all over the newspapers. They were like, this nurse died after being vaccinated. And I'm sure you've seen this in real life and it has happened in your countries with COVID-19 vaccine. It says right here, no conclusive answers from the authorities yet. The fear is growing and it has gripped the entire Puerto Alto nation. All of that. And then later on, you receive a second report. I can't read this, I'm gonna read from here. Is the death of another person following vaccination. This time it was a 90-year-old resident of a long-term care facility. Both received the same vaccine from the same batch. It's just 2 different vaccination spots. The impact, you've been receiving calls and messages and people are worried, they're concerned about how come these 2 men in different vaccination sites, they died? You know, what is happening? Of course, they both had comorbidities. They were a bit older. The person that was 90 years old at the time of the vaccination had some symptoms of pneumonia. But this has been great, and thank you everyone again.